And now it is my pleasure to welcome our next speaker, Dr. Jennifer Kelly. Dr. Jennifer Kelly is the director of the Atlanta Center for Behavioral Medicine in Atlanta, Georgia, and is the 2021 past president of the American Psychological Association. Board certified in clinical health psychology, her primary presidential initiative at APA was focused on psychology's role in achieving health equity. In 2018, Dr. Kelly served as co-chair of the newly formed Advocacy Coordinating Committee of the American Psychological Association Services. And for 23 years, she has served as the Federal Advocacy Coordinator of the association. A graduate of the 2003 class of Leadership Atlanta, Dr. Kelly has been recognized on numerous occasions for her advocacy on behalf of psychology, including recognition from the APA Services Practice Leadership Conference and a legislative award from the Georgia Psychological Association. We're so happy to have you here with us today, Dr. Kelly. Welcome.
Thank you so much for allowing me to be here to discuss my presidential initiative. I will start the screen share. And I will say good morning and good afternoon, depending on where you are in this world. I would like to spend some time with you talking about and discussing my presidential initiative, which was last year. I was a 2021 president. And I would like to also put in some information about what it is that we can do to make a difference as it relates to achieving health equity. So these are some of the objectives that I have here for today. And I really want you to have some understanding about how the current healthcare practices contribute to health inequities. And identify and understand how environmental and social factors systematically contribute to health inequities. And so I want to move and get specific about some health disparities and the incidence of cancer and treatment outcomes, and look at finally be able to understand, articulate at least some ways in which psychological science and practice can help address the health inequities. So when you think about health, it's really more than just about healthcare. There are so many factors that are associated with health, whether or not it's patient protection, insurance coverage, your interactions that you have with the provider. You're talking about financing. So we're talking about more than just healthcare. When we talk about health disparities, the CDC defines it as preventable differences in the burden of disease, injury, violence, or the opportunities to achieve optimal health that's experienced by individuals who are socially disadvantaged. And I did want to highlight those two things. It's preventable and it's by socially disadvantaged populations. Again, I highlighted the social disadvantages, and the WHO says that when you look at health disparities, they are significantly associated with social disadvantages. But the WHO says they're systematic and they are avoidable. And we know that they are facilitated and exacerbated by the circumstances in which people live and work, and they are intensified or influenced by political, economic, and social factors. So when you start thinking about health disparities, what you're thinking about is that you have certain groups who have systematically experienced greater obstacles to health. And they are based on many of these factors here. And what I did was I did highlight mental health because that is what it is that I do. But all of these factors impact on one's ability to achieve optimal health. When you think about health disparities or health inequities, you have to think about the social determinants of health. And they are the conditions in which people are born, grow, live, work, and age. And we know that they are influenced by these socioeconomic, these factors such as socioeconomic status, how much money you earn, the income that you have, the level of education that you have. How far did you go in school? Did you have vocational training, higher education? Your level of literacy, the neighborhood in which you reside, whether or not you have sidewalks within your neighborhood, the zip code in which you reside, the community in which you live, the kind of support that you can have in your community, and whether or not there's increased exposure to violence or trauma within your community. And of course, the healthcare system, your health coverage, your ability to interact with the provider. And what we know is that what goes throughout those factors are racism and discrimination. So you cannot think about the social determinants of health unless you look at it within that context. And from that, we get the health outcomes. So I want to spend a little time with you, giving you information about the evidence related to health disparities. So I want you to compare this to the non-Hispanic whites, and that's the number roughly 6% down at the bottom, as it relates to health insurance and coverage. So the number uninsured, you have 16% of Latinx, roughly 15% of American Indians and Alaska Natives, probably 10.5 or 10.6% of African Americans that are uninsured. As it relates to the chronic health conditions, you have people who are reporting fair or poor health. You have 17.4% of American Indians and Alaska Natives reporting fair or poor health. And 14% of African Americans, 10% of Latinx, and you want to compare that to roughly 8% of the non-Hispanic whites. As it relates to chronic health conditions, you have 42% of African American adults suffer from high blood pressure compared with roughly 29% of white adults. 80% of African American women are overweight or obese compared to about 65% of white women. And you have 21.5% of Hispanic adults having diabetes compared to 13% of white adults. And here's another statistic. Asian Americans are 40% more likely to be diagnosed with diabetes than white Americans, and they are also 80% more likely to be diagnosed with end-stage renal disease. In terms of the leading causes of death, what we know is that there are 11 infant deaths per 1,000 live births among Black Americans. And this is something that's getting more attention, not just in the media, but more legislative focus, because this is almost twice the national average of 5.8 infant deaths per 1,000 live births. As I started really looking at the research, it became really starting to me to see the health disparities in the Indigenous American. And I wanted to spend just a little time talking about that. So one of the things that we know is that they have experienced just in lower health status when you compare them to other Americans. And it's related to inadequate education, disproportionate poverty, discrimination, and delivery of health services. And the American Indians and Alaska Natives that are born today have a life expectancy that's 5.5 years less than the US all races population. You're talking about 73 years to about 78 and a half years respectively. And the American Indians and Alaska Natives continue to die at much higher rates than other Americans in many categories. And these include such things as chronic liver disease, including cirrhosis of the liver, diabetes, unintentional injuries, assault, homicide, suicide, and chronic lower respiratory diseases. And the suicide rate is 3 to 6 times higher among American Indian and Alaska Natives than among their non-native peers. And this is one of the main concerns that they have. And they're really trying to understand this, but one of the things that they think can account for this is the lack of adequate funding of the Indian healthcare delivery system. So I wanted to spend a little bit of time talking about race, place, and health. Where you live really does matter. So this is a little bit busy, but I want you to just look at the light blue columns and the dark blue columns, and I'll tell you what it shows basically, is that the Black children in counties with high segregation, and that's indicated by the light blue columns, they experience worse poverty, higher infant mortality, which we just mentioned, and lower high school graduation rates than those in the less segregated counties, which are represented by the dark blue columns. So where you live really does matter. So the link between race, place, and health, it has really been in large part just related to that history of unequal access to opportunity in the United States. And it's based on the history of policies and practices that just really systematically denied these things to people of color. So addressing these health inequities that's caused by the residential segregation will really require initiatives that are localized, multi-sectorial, as well as equity focused. So I wanted to spend time talking not just about what we see in the United States, but there are disparities globally. And so, for example, for age, what we know is that 94 people over the age of 60 may have made up 94% of the COVID deaths in the European Union. Just staring at us is that we see 2/3 of the children under the age of 5 who suffer from stunted growth are from Africa and Southeast Asia. And you can also see it as relates to race and ethnicity, gender and sexual identity, as well as socioeconomic status. So if you look at things from a global standpoint, it seems like there are positive trends that are going on in terms of looking at health status and more health equity. However, if you do more detailed observations, what you see is that there's a persistence of health problems and diseases that really should have been eradicated by now, or they should at least have been more controlled. And one of the things that we're also seeing is that we're seeing more inequities, sometimes across nations, but also within nations, and with among the social or racial ethnic groups, which is one of the things that we see in the United States. And according to the WHO, the income level of a country has a direct correlation with life expectancy. And the life expectancy of low-income countries 18 years lower than the high-income countries. The other thing that we know is that there's an estimated 800 million people worldwide who are chronically hungry. And it's ridiculous for this to exist because what we have is enough food production to cover over 120% of the global dietary needs. So we have a lot of work to do. As it relates to mental health, the number of suicide attempts by adolescent Latinx females was 40% higher than that of white females. And there's been a lot of research to really try to understand what that's all about. And suicide was a leading cause of death for Asian Americans ages 15 to 24. And the second leading cause of death among American Indian and Alaska Natives between 10 and 24. One of the things that we knew is that, yes, health disparities existed. We knew about health inequities, but when COVID hit, it really heightened our awareness of that, and we really got to see health disparities really just staring us in the face. And what we have found was that the Black, Indigenous, and people with lower incomes, older adults, and people with disabilities, if you think about all of those factors, they have the largest impact from COVID-19 in terms of infection rate and mortality. And globally, one of the things that we've seen is that it really halted the critical mental health services that really have been needed. That's in 93% of the countries. And we know that the demand of it has been increasing. Now, this is what the latest that I could find was in September of 2021. So it's about a year ago. And this is what we were seeing as it related to the cases, hospitalizations, and deaths from COVID-19 infection. So this is compared to the white non-Hispanic persons. And I'm just going to go to the one with deaths. So the American Indian, Alaska Natives were 2.4% likely to die, more likely to die from COVID. And Black Americans and non-Hispanic persons, 2%, and the Latinx or Latino persons, 2.3%. So why was there such a deadly toll of COVID-19 on the Indigenous population? So we know that historically, the population has experienced a higher degree of socioeconomic marginalization. They have a disproportionate risk for public health emergencies. And they do not have the same access to effective monitoring and early warning systems, and they also lack adequate health and health services. The other thing that we know is that they have high representation in the service populations. And these are things that I found that were more startling. So the older age, multi-generational housing, lack of running water, communal wells, all of these things just increase the impact of COVID-19. And I did not know this, that 40% of the Navajo households did not have access to running water, and 30% do not even have electricity. So the marginalization, segregation, and discrimination of these tribes really impacted on their ability to manage within the COVID-19 situation, which, by the way, I think that we're still in. And we also know that it's had higher death tolls on the Black Americans and the Latinx. And one of the things that we know is that bias plays a role in it, with either explicit bias or unconscious bias. And it's, for example, determine if a patient will receive proper testing and treatment in the early stages of COVID. And the Black Americans have a much higher prevalence of the health conditions that increase the risk of death from COVID-19, such as diabetes, high blood pressure, and heart disease. And the African Americans, the Black Americans, and Latinx are less likely to be able to work from home. And they're forced to take public transportation, increasing their risk of exposure to COVID. And many of the minority and low-income communities are likely to experience food insecurity. So you're going to have higher rates of obesity and diabetes, and that's also one to make them more vulnerable to COVID-19 and the effects from that. And we know that decades of segregation, discriminatory housing policies, as well as poor environmental protections have left many African Americans and Latinos living in substandard and high density housing, where there's higher air pollution, leading to higher rates of asthma and other diseases. And the other thing that we know is that the minorities are more likely to live in the healthcare deserts, in which they do not have the same level of access to the primary care physicians or even the emergency rooms. And one of the things that's happening here in Atlanta is that one of the, we have two hospitals in Atlanta that have a level 1 trauma center, and one of them's closing. And that's partly because the governor just did not approve to have Medicaid expansion. So, and it's an inner city hospital. So it will take a longer distance to get to care that they need. So one of the things that we know is that health is not a direct result of behaviors and actions. And yes, we do know that the individual actions and behaviors can play a role in health, but more importantly, the environments in which they exist and the policies that are put in place that shape people's opportunities determine what choices they have to make. And one of the things that we also saw during COVID-19 was impact of mental health. How did it impact the mental health? And you can see the symptoms of anxiety and depression during the COVID-19 pandemic by race and ethnicity. And you see the non-Hispanic Blacks and Hispanic Latinx have the higher rates. You want to compare that to all adults. The other thing that we have been finding is, since we've had an expansion of telehealth services, and we thought that it would be have increased access to mental health care, but we have to be aware of how this can impact on people of color or more marginalized individuals. So, for example, you have to have access to high-speed internet or broadband in order to have the equitable services. And you have people who just do not really know how to use the technology. They may have difficulty hearing, can't use a telephone, or they may not even have enough minutes on their telephone to allow them to have access to these services. So we have to be aware of that. So one of the things to think about as relates to racial and ethnic disparities, not just from the moral and ethical reasons why you want to improve that, is that it costs. And so a 2011 study showed that the economic cost of health disparities due to race for African Americans, Asian Americans, and Latinos from 2003 to 2006 was over $229 billion. And the Urban Institute calculated that the Medicare program, just the Medicare program itself, would save close to $16 billion per year if healthcare disparities were eliminated. And that's significant. So I want to spend just a couple of minutes talking about health disparities by race and ethnicity as it relates to cancer health disparities. Studies have consistently shown that African Americans have the highest mortality rate from all cancers combined compared with any other racial or ethnic group. As it relates to multiple myeloma, the incidence and mortality rates are twice as high in the Black population as in the white population. And transgender men are more than twice as likely to get cancer than cisgender men. And for people living in rural communities, the combined death rate for all cancers is 17% higher than it is for people in the rural areas. And if you look at this, this chart, this graph really shows it. So if you look at the death rate, and you can see as it relates to the Blacks, you can see that they, and male and female, they have the highest incidence of deaths from cancer, highest rates of cancer deaths compared to any other group here. Now, as I started doing the research about this to provide some slides, I came across this study that just recently came out. It was in August of this year, and it was published in Advances in Radiation Oncology. And so researchers from Huntsman Cancer Institute at the University of Utah found significant healthcare delays for people of color when they tried to obtain this more advanced targeted form of radiation therapy called intensity modulated radiotherapy, radiotherapies is IMRT. And what that intervention does is it matches the precise contours of the tumor to minimize dose. So it will allow for decreased side effects and improves quality of life. So you're not going to have as other tissues as involved. It's more expensive, and many insurance companies require prior authorizations, which would sometimes would allow, which would result in delays in treatment. But this is what they found as they were looking at this. They were not looking for this, but they found these results. They found that Hispanic, Black, Hispanic, and Asian patients were significantly more likely to have delays in the initiation of treatment with this procedure compared to non-Hispanic white patients. And it was across nearly all included disease sites. The other thing that they found out was that although private insurance was associated with more timely treatment in white, Hispanic, and Asian patients, the Black patients with private insurance had longer delays than those with Medicare. And they were not looking at that, but that's what they found. As it relates to mental health condition, it's estimated that up to 1/3 of the people treated for cancer in hospitals have a common mental health condition, and the rates of major depressive disorder are thought to be up to 3 times higher with cancer patients than in the general population. And there's a range that approximately 8 to 24% of people with cancer are also living with depression. And it also shows that youth and young adults are a greater risk of depression and other conditions compared to other adults with cancer. And studies have shown that those who are dealing with mental illness, dementia, and substance abuse are more likely to have lower chances of survival after the cancer diagnosis. And one study found that those who received the treatment and had fewer symptoms of depression had longer average survival times than those who had more symptoms. So we know that it's important to treat the mental health symptoms. And they also showed that they have better medical care and a better quality of life. And that was a meta-analysis that identified about 3,700 studies. And about 70% of these, of the people that they looked at were female. And they range all from between 18 and 79 years of age, and all the continents were included with the exception of Africa. And what it showed was that people with mental illness are less likely to undergo screening for cancer than the general population. And they found that this to be particularly true of women and for people with schizophrenia. And they said, while people with mental illness were less likely to receive the screening than the general population in any part of the world, they found the greatest difference in Asia, and the least difference was found in Australia. And so they found out that the cancer screening programs that work with the general population really do not appear to work as effectively with people with mental illness, and we need to start doing something very different to have the reach for the patients with the mental illness. And they found disparities in the rural population as well. So the rural cancer survivors reported more greater symptoms of anxiety and depression, greater distress, and more emotional difficulties than in the non-rural cancer survivors. And we also know that the people in the rural areas do not have as good of access to healthcare. And you start thinking about that when you start looking at the expansion of telehealth services as well. So we really need to start looking at that. As it relates to the veteran system, the VA system, and one of the things that they found is that veterans with mental health conditions were more likely to die of lung cancer or from any other cancer than those without the mental health conditions. And they found that if they did receive the treatment, they have better success, better prognosis. And so in one study, when they saw that of more than 50,000 veterans that were treated with lung cancer within the VA system, and they received the treatment, including substance abuse treatment, they lived much longer than those who did not receive the treatment. And so they also found that the support was much more, was quite important for them to have. So mental health treatment and the support will be important for that population. So here's a study from the American Association for Cancer Research. This was the progress report of 2022. And so it identified the priorities that policymakers need to undertake in terms of addressing the disparities in cancer. Increase funding for research and public health initiatives that's aimed at addressing the disparities. Improve the collection of data, increase the diversity in the clinical trials, and support cancer prevention and screening programs to have better outreach and access to more affordable and equitable mental health care, and to recruit a more diverse workforce in science and other medicine-related fields. And the interesting thing is that these are the same recommendations that my task force came up with, as we will see. So one of the things that Martin Luther King said was that of all the forms of discrimination and inequalities, the injustice in health is the most shocking and inhuman. So I want to move away from the health disparities to move towards health equity. And what we know is that what we want to do is to have the attainment of the highest health of all people and to value everyone equally. And it will focus on ongoing societal efforts to address avoidable inequalities or inequities, the historical and contemporary injustices, and the elimination of health and healthcare disparities. Equality is not the same as equity. So, because if you look at on the left side, you can see equality, where they all have access to that same box, right? But not all can reach the fruit. But if you look at equity, what you're looking at is giving the people what they need, when they need it, and the amount that they need it, so that they all can have access to that fruit. So what it would mean is that everyone will have a fair and just opportunity to achieve optimal health. And it means reducing and ultimately eliminating disparities in health, as well as those determinants. And you have to address mental health if you're talking about health disparities. And we also need to focus on the social determinants of health. And I put this slide in because I think that it's important. So what it does is it looks at the medical model on the right side and the socio-ecological model on the left side. And this is developed by the Bay Area Regional Health Inequalities Institute. So what it's showing on the medical model is saying that our health is influenced by a combination of our access to healthcare, genetics, and personal choices. But guess what? This model is only responsible for about 30% of our health outcomes. The other 70%, the socio-ecological model, lies within our social, political, and economic environments. So what we know is that the systems and the rules and practices they enact and promote determine the distribution of resources and who has access to them. So if we're going to address health equity, we really have to look at how structural racism really plays a role in this, and discrimination. So in order to make a difference, we have to focus on dismantling racism in our science and pedagogy. So given all of that, this was my initiative, was looking at what psychology's role would be in achieving health equity. And so what we know is that their environmental, social, and behavioral factors contribute to health disparities in interacting ways. But we also know that these are all within psychology's expertise. And so it is up to us to really try to find, number one, and find the concrete ways to make improvements in in the populations, but also how do we go about enacting those and making that difference. So I put together a task force on psychology and health equity, and I was really wanting to get people with a broad level of expertise in all the different areas and the ones that could really make a difference in what it is we were trying to do. So if these are the people that we ended up having as part of our task force, and I must say that it was quite a broad group of people, and from independent practice to researchers and in medical school environments. And even the co-chair has been with the WHO, Dr. Jeffrey Reed. So one of the things we wanted to do was really articulate a vision for the role of psychology in advancing health equity. And we wanted to develop recommendations to promote really the innovative approaches for psychological science, education and training, practice, and public policy and advocacy. And we wanted to give these recommendations to the various organizational units of APA. And we also wanted to have a policy, and not just one that will be put on the shelf, but some things that APA can really enact as it results in, that can result in making a difference in terms of psychology's role in achieving health equity. So these are some of the products that we had. We had the summit meeting, and there's a special issue of American Psychologist that focuses 100% on health equity. We had a presidential programming at the convention last year, and the recommendations for the policy. And we wanted to have all voices included and look at all of psychology, and not in silos, but what we can bring to the table. And so we had that roundtable meeting that really received information from our stakeholders within psychology that could help us in terms of articulating that the vision of what psychology's role could be, and give us some concrete recommendations of what we can do. So one of the things that we knew is that it was becoming real clear that yes, psychology can make a difference, but we also knew that we had to do some things within our own house if we wanted to make a difference. Because remember, I talked about racism and discrimination just is threaded throughout health and health disparities and within the social determinants of health. And so we had 3 major resolutions that were passed at our last council, the council meeting in October of 2021. And one was the apology to the people of color for the role of APA in promoting, perpetuating, and failing to challenge racism, racial discrimination, and human hierarchy in the United States. And the second resolution was the role of APA and psychology in dismantling systemic racism against people of color in the United States. And our third resolution was advancing health equity in psychology. Now, and these are the links to all of those resolutions. And one of the things that you can do is just go to apa.org and just type in apology to people of color, and you will be able to get all of those resolutions. And please spend some time looking at those because they were very thoughtful. And I'll give you some highlights of the health equity resolutions, but the main, this is resolution number 1. And so this is the main focus of that apology. So we had a historical chronology that was conducted by the Cummins Center on the history of psychology. And we had a series of listening sessions to capture the oral history as well as just to look at the written history. And we also had a public survey that we spearheaded. And it's really a broad-based apology to people of color. And it just presented a series of action steps in which we can do to make a difference. And this second resolution was really to look at our role in helping to expose, understand, and ultimately dismantle racism across all these different levels. So the first thing is to apologize for what it is that we've done. Now, okay, we've apologized, and now we can really make some changes. And these are some things that we can do. And then the third resolution as part of that package is in health equity and psychology. And so in education and training, one of the things that we did is that we made these recommendations. Support comprehensive evaluation of early psychology exposure, recruitment, admission, and retention processes. And we wanted to really reach out to recruitment programs and really target undergraduate programs, tribal colleges, and high school. We wanted to have a diverse profession. And we want to have also health equity included in psychology curricula. And we know that not every training model, not that box training model will work for everyone. So we want to encourage more traditional, more flexible training models for graduate education, and also have mentoring programs to really, not just mentoring of the students, but mentoring of the faculty as well. And we wanted to support training programs throughout the training sequence, including support funding for curriculum development. And we really wanted to have health equity infused into the programs. We wanted to advocate for federal research funding agencies such as NIH, NSF, and HRSA, and private foundations for dedicated, sustained, and increased funding for research on health equity. And we also wanted the research to include scholars of color, the ones that really have that knowledge about health equity issues. And we also wanted there to be more collaborative efforts with the historically Black colleges and universities and the tribal colleges. And we wanted to have promote really having more authors and scholars of color involved as journal editors. And we wanted to minimize the bias, because we understand what some of the challenges are, and we have to make a difference and dismantle some of these the difficulties that we have. As it relates to professional practice, we really wanted to support innovations that deliver competent as well as financially viable assessment and treatment, as well as prevention for diverse populations and communities, and have more CE programs for practitioners. And we wanted to advocate for health insurance service reimbursement that will cover more diverse models. And we wanted to have advocacy really throughout the entire process. And we wanted the development of the training models and support the training programs to help students really enhance their advocacy skills, as well as partner with other coalitions and other professional and policy-making organizations to address health equity issues in communities of color. So we had this great package about health equity, and we had the resolutions, all three of those resolutions. And so we wanted to not just sit up on a shelf. So one of the things that we did is, as part of this resolution, we said, these are the things that we want. Well, we've already had the audit of the APA activities on health equity, and that was in February of this year. We had that, and it was a pass, and we saw all the things that were done. We wanted to have a 5-year implementation plan. And so one of the things that we wanted to do is to have the CEO come back to us, the executive leadership team, and say, this is what we're doing. We have 5 years for doing this. The other thing that I think that's important to note that we have is that we just approved in August of this year the racial equity plan, and APA has committed $1.1 million to the plan. But we know that in order for this to be successful, it's going to have to be more than just us. We have to have people of color to be part of that. So I'm going to finish by the recommendations for a more equitable mental health system. And one of the things that we need to do is to work more upstream. And so if you're working more upstream, what you're going to see is that everyone in all communities should be able to have safe neighborhoods, fair standards of living, we can dismantle racism and have a more healthy environment. So we want action on that societal level. As we do that, we will have less downstream, less homelessness, less poor health status, less obesity, less incarceration. We want to address the social determinants of health, embed the services in the places where people go. And we want to empower people to be healthy, to have that screening, and work with people who are healthy, as in addition to working with people who do have the mental health challenges. And we want to broaden the set of interventions that we use. Let's go out into the community and focus on health at the community level. And we want to really work on improving mental health literacy. And we want to reframe how people view mental health. That is something that is inside of all of us. And so as part of my presidential initiative, one of the things that I did was I wrote an article, and you can take a shot of this, and please go to this, and it's Building a More Equitable Society, Psychology's Role in Achieving Health Equity. And it's in the American Psychologist, and it just came out. So thank you, and I am now available for questions. I am only 2 minutes over. No, I'm only 1 minute over for questions. So thank you.
Thank you, Dr. Kelly. You're right on time. 1 minute or 2 minutes. That was a wonderful, wonderful talk. There is a question here that's come in about unconscious bias. So you touch a little bit on conscious and unconscious bias, and what strategies would you recommend to deal with unconscious bias? And are there any tests that psychologists use to determine unconscious bias?
Well, that's a good question. And I don't know if that, and I'm sure because they have tests for everything now, but I'm sure that we could find a test for that. They talk unconscious biases. There are things that other terms for that. It could be hidden racism, or we can call it microaggressions. But I think that one of the things as it relates to unconscious bias is that if we see it, then I think it's our responsibility to bring that up to our colleagues and say, hey, I think that there is something going on here. So we may not be aware of it, but there are other people that we're working with, our colleagues are aware of it. And so we have to have the courage to just let people know what's going on here. And as I was stating, that it's not up to the people of color to do this. I mean, we can only do so much, and we're going to need our colleagues to help us through this process. Mm-hmm. And it's like, well, you don't really, I guess you could do a test for it, but there are many diversity kind of training programs out there that can really focus on this. But I bet if you can Google it, we can find that there are tests that will look at unconscious bias.
Right, I'm sure. Thank you. Yes, it's we're all in this together. So
right.
That up, and like you said, having the courage. Let's see. There's another question that has come in. What are practical steps an individual mental health professional can take to have an impact on health disparities?
Oh gosh, yes. And so one of the things, I'll tell you about my practice. I'm a mental health professional. I'm an independent practice. Uh-huh. So one of the things that I've done, but some people say that I'm different in this regards, because I've been out for a very long period of time. And most of my colleagues don't even take insurance anymore, because they've had such a, they've been out for so long, they have a standard of living that they want to aspire to. But one of the things that we can do, I would say, is to put time on our schedule, number one, to work with people who don't typically have access to that care. I'm a Medicare provider. Because I believe that everyone should have access to adequate mental health care. And I am on insurance programs. I very rarely see, it's very, very rare that I see patients on cash basis, because the population that I work with as a health psychologist, many of them do not have that kind of money. So I would say to you, number one is be able to open up your practice to people who don't necessarily have access to the kind of services that would be higher pay services. The second thing is look and think about what you can do in terms of improving your knowledge in working with these diverse populations and your competency in working with diverse populations. And most state psychological associations now, if you go to their annual meetings, they are having more of their programs that are focused on working with people of diverse populations. So it's like, look at some of those and really try to increase your own competence and confidence in working in with these populations.
Thank you. And a comment. Oh, where did that comment go? Somebody, you were right. There's a test for everything, Dr. Kelly. Oh, here we go. A participant here recommended the Harvard IAT as a test for implicit bias. So
there you go.
Test for everything. There's something that I want to ask you just from the heart. I am not a therapist. I'm not a clinician. I'm just a person working here in Los Angeles in this cancer care landscape, trying to ensure that all people have access to the care they deserve. And your presentation was so moving to me because the statistics, they're not only sobering, but they're heartbreaking. And I have to say that I had a sense of overwhelm. And I'm just wondering if you have any advice for those of us working in this field and how to strategies to deal with that sense of overwhelm.
Right. Thank you for saying that. And I think that one of the things that happened is that when I started looking at all those statistics, if you focus on those statistics, it can be just so overwhelming. And it's like, so first of all, the question is, well, racism doesn't exist and, health disparities don't exist. And then I present the science and I present the data. And it's just like, people would just like sit back in their chairs, like it is what it is. So one of the things that I said we need to focus on now is to move away from that because it can be so overwhelming and look at and think about what it is that we can do to make a difference because the statistics are out there.
Yeah.
And the data's out there. And so what it is that you can do, how do you open up your practices, whether it relates to working with people with lower socioeconomic status, working with disadvantaged populations, what it is that you can do to increase your confidence and competence in working with this population. So I've been trying to move away from health disparities, knowing that it exists because it's part of the work that I do as a clinical health psychologist, and moving to like, okay, my focus is how to help this person navigate the healthcare system, how to help them go about having that access to care that they desperately need. And I have found myself really, if I allow myself to start focusing on, it's like, I'm going to help this patient navigate this healthcare system. And many of them just do not know how to do that. They don't have that health literacy. And so think about what it is that you can do to try to help make a difference. I had no idea that I would have such a groundswell with my colleagues with APA when I took this on as my initiative. What I did know was that when I was thinking about it, was like one of the things that characterized my practice was I saw a lot of health disparities. And I knew that if I was having this challenge, then other people will be having these same challenges. And then 1 month later, when I said that I was going to have this as my initiative, then COVID hit. And then we started seeing health disparities right there staring us in the face. So the other thing that I'm going to say to you too is that if you're working with this population, always make sure that you're taking care of yourself as well, because it can really be draining. So make sure that you're doing the things that you need to do for self-care.
Thank you. Good advice. Well, I think that we're at time, and as you said, psychology can make a difference. And I want to thank you so much for your presentation and for enlightening us and educating us. We really appreciate it, Dr. Kelly. And I hope everybody will check out that article that you mentioned at the end of your presentation.
I appreciate it. Thank you.
Absolutely. Absolutely. Take care.